Welcome to RadClerk Demos. Today we have Emily Ploom who's going to take us through this chest radiograph. Emily?
Okay, so it looks like today our case is a 69-year-old patient with hypokalemia. So before we start interpreting the study, we just want to make sure that we're looking at the correct patient's chart and we have the right study open. So first, we'll confirm the identity of the patient by looking at two constant identifiers. In this case, their name and their date of birth. And then we'll also ensure that we have the most current study by looking at the date and also the time of the study as well. Okay. So it looks like we have the correct patient and the correct study. So now we just want to ensure that the technique is adequate. So we'll use the acronym RIPE-F, which stands for rotation, inspiration, projection, exposure, and field of view. Okay, so to assess for rotation, we're just going to check to see that the spinous processes are centered in between the clavicles. In this case, we can see they are, so the patient is not rotated. So next for inspiration, there should be about 8 lucencies in between the ribs. So in this study, we can see that there are about 7. So we can see that there is an adequate inspiration with some low lung volumes bilaterally. So for project, it's an AP study. So the cardiomyostinal silhouette will appear a little bit larger relative to a PA study, as in this case. So to assess for exposure, we want to see that the intervertebral discs are distinct from the vertebral bodies. And by window and leveling, we can see that the study is not underpenetrated or overpenetrated. So next, we want to assess for the field of view. So we want to see that the lower neck is included and also the lung apices superiorly. And then we want to see that the upper abdomen is included inferiorly and that we can see the full extent of the diaphragm, which we can. So the field of view is adequate in this case. So next, we want to assess for pathology. So we'll do the acronym ABCDE, which stands for air, bones, cardiomediastinum, diaphragm, and everything else, which includes the upper abdomen, tubes, lines, and devices. So starting with air, we can start by assessing the airway, the air spaces, and the pulmonary vasculature. So starting at the trachea and bifurcating into the bronchi, I do not see any peribronchial thickening of any sort. Looking at the air spaces, I see that there is an opacity in the right upper zone of the lung, and this likely represents lobar collapse based on the pattern. I can see that there is some upper displacement of the horizontal fissure. There's also a loss of definition of the right upper mediastinal margin, and also increased translucency of the rest of the right lung due to some compensatory inflation of the middle and the right lower lobes. But most of the time, collapse of the right upper lobe is due to resorptive atelectasis. So that's when the air is just resorbing the blood and the lobe collapses. My differential for this case would be mucus plugging or perhaps compression by an adjacent mass. So next, I'll assess the rest of the lungs. So I will look for pneumothorax by tracing the pleura. And in this case, I do not see any visceral pleural lines. And I also do not see any gas. So there's no pneumothorax in this case. So next, I will look at the pulmonary vasculature. And I do not see any vascular congestion or any edema. So next for B, which is bones, we will window and level. So we'll be looking at the cortical medullary bone, and we can zoom in to look at details. We want to look at the vertebral bodies for any compression fractures. So you just want to look at the height of the vertebrae, and it looks there is no pathology in that case. And now we move on to the ribs. So we'll start posteriorly and trace the ribs anteriorly, going one by one and bilaterally. In this case, I don't see any pathology in the ribs. Next, we'll look at the clavicles, and I'm not seeing any pathology in the clavicles either. And then we'll look at the scapula and the humerus bilaterally as well. So in this case, there's no pathology of the bones. So next for C, we'll move on to the cardiomediastinum. So when looking at this, we remember that this is an AP radiograph. And in this case, the heart is normal because an AP radiograph will make the heart look slightly magnified. Next, we want to look for D, which is the diaphragm. We'll be looking for the costophrenic angles bilaterally. In this case, they are sharp and there's no blunting, so there's no pleural effusion. Also, we want to look at the height of the diaphragm. So in this case, maybe there is some slight right hemidiaphragm elevation, which is likely due to the collapse of the right upper lobe. Okay. So next we'll move on for E, which is everything else. So we'll look at the upper abdomen first, which looks normal in this case. And then we're going to look at the tubes, lines, and devices. We're going to start with the right internal jugular central venous catheter. So over here, we need to look at its tip, and we can see that the tip is about 1 vertebral body below the carina, which is in the lower superior vena cava. Okay, so next I can see that there's an enteric tube. So the enteric tube, we can see it courses midline and then it travels inferior to the diaphragm with its tip inferior to the field of view, and it is adequately placed. And then we can also see we have an endotracheal tube. And we can see here that the tip is above the carina, which is adequately placed. In summary, this is a 69-year-old patient with hypokalemia with a chest X-ray showing low lung volumes bilaterally, right upper lobe collapse with enteric tube and endotracheal tube. And there is also an internal jugular central venous catheter with a tip in the lower superior vena cava.
Good work on this case, Emily, and great job on the rotation.
Thank you.